Good morning. I am at-large Councilmember Christina Henderson, Chairperson of the Committee on Health. I'd like to call this hearing to order. Today is Thursday, March 30th, 2023. The time is 9:04. We are holding a hybrid meeting in room 123 of the John A. Wilson Building, as well as via the Zoom internet platform. This meeting is also being broadcast live on cable channel 13 and on my YouTube page at CMC Henderson. Today, we are holding the fiscal year 2024 budget oversight hearings on the DC Health Benefit Exchange Authority and the Not-for-Profit Hospital Corporation, also known as United Medical Center. This afternoon, we will come back for first part of the hearing for the Department of Behavioral Health. First, we will hear testimony from public witnesses, as well as then from Mila Kaufman, the Executive Director of the DC Health Benefit Exchange Authority, as well as Diane Lewis, the Board Chair of the Authority. The DC Health Benefit Exchange Authority, HBX, was established by the District of Columbia to develop and operate the Affordable Care Act online health insurance marketplace or exchange for residents and small businesses in the district. It is formerly known as DC HealthLink. HBX is a public-private partnership established to foster competition and transparency in the health insurance market. HBX enables individuals and small businesses to compare health insurance prices and benefits and to purchase affordable quality health insurance. DC HealthLink offers health insurance plans from United Healthcare, Aetna, CareFirst, Blue Cross Blue Shield, and from Kaiser. The committee sent written pre-hearing questions to HBX, and we will reference those materials today. For anyone who would like to see those materials, they can be found online on the council website at dccouncil.gov. Before I turn to my colleagues for opening statements, and I don't see them, but I'm going to say this for the record. I want to address the recent online attack that resulted in a breach in HBX's data earlier this month. Since the breach, Director Kaufman has consistently kept the council updated on HBX's response and their collaboration with law enforcement. There is an ongoing investigation being led by the FBI. As such, we will limit our discussion today as it pertains to the data breach, and there may be some questions that Director Kaufman is unable to discuss at this time, as it would compromise the investigation. The Committee on Health and the broader council are monitoring the ongoing data breach response, and Director Kaufman has offered confidential briefings to any council member who would like to receive one. With all that said, I don't see any of my colleagues, so I'm not going to turn to them for opening statements, but I'm going to get started with the public witness testimony. Just to review the guidelines for public witnesses, if you're representing an organization, you will have 5 minutes to speak, and witnesses testifying on their own behalf will have 3 minutes. We have a clock that will begin counting you down once you begin speaking, and I will give you a nudge when your time has expired. As I've noted, we have quite a bit going on today. Okay, since we have 16 public witnesses, I'm just going to do panels of 8 and 8 so we can do 2 panels and move on. So I'll call up the folks. Just for the technical, for those who haven't joined us before, you have to affirmatively accept our invitation to become a panelist. Rachel Ellison, Kimberly Perry, Rebecca Barson, Nicole Baroga, Chai Rubel Sizabola. Apologies if I'm butchering your names. Veronica Hernandez, Lisa Nip, and Angela Franco. Again, if you are in the witness room, you have to affirmatively accept our invitation in order for us to see you. All right, don't see a Rachel Ellison, but I do see Kim Perry. So we'll start with Kim. Good morning.
Good morning. Thank you so much. Can you hear my audio?
Yes, ma'am.
Great. Good morning, Chairman Henderson, Director Kaufman, and members of the Committee on Health. I'm Kim Perry, Executive Director of DC Action, and I'm also one of the co-chairs of the Under 3 DC Coalition. I'm here today to request that all funds allocated to the DC Health Benefit Exchange for the purpose of full implementation of healthcare for childcare and any related communications, outreach, and marketing remain steady in their budget, and if at all possible, allocate sufficient dollars in all 4 years of the financial plan. Healthcare for childcare, funded through the Pay Equity Fund that the DC Council established in 2021, is one of the first and only programs in the country providing free or low-cost health, dental, and vision benefits to employees of early education programs. Before healthcare for childcare, very few early learning programs in the district were in a financial position to offer health insurance to their employees. Often margins are too thin to afford premiums, and historically wages have been too low to participate in any cost sharing for employees. But the Pay Equity Fund is changing all of that. The more than $18 million provided to the Health Benefit Exchange through a memorandum of understanding with the Office of the State Superintendent of Education, who administers the Pay Equity Fund, is of great value, and it's already making a significant impact on the lives of employees in the early learning sector and their families. Once the dollars were made available to the Health Benefit Exchange, Mila Kaufman and her team immediately deployed resources to gather data and begin conducting in-depth interviews with early learning programs to gain a full understanding of their current health offerings. And in a short period of time, they took what they learned and they created Healthcare for Childcare. It's a product uniquely designed to meet the needs of the early learning sector. I admire the persistence and the tenacity of Mila and her entire team to solicit ongoing feedback about the benefit package and engage the early learning community in outreach and marketing of the program now that it's up and running. The result is more than 61 employers now enrolled in the program, covering 557 employees and 99 dependents. And with the outreach plans and outreach grants they have in place, no doubt enrollment will grow over the remainder of this year. But one of the barriers to participation is the perception that healthcare for childcare doesn't have steady multi-year funding. So we ask the committee to ensure that funding for healthcare for childcare is included in the FY24 budget and well beyond. Our coalition supports including funding for the program in all 4 years of the financial plan. Again, health insurance is a valued aspect of compensation for any employee. Healthcare for childcare is already having a deeply moving impact on the early learning workforce. Along with higher salaries, it allows our employees to stay in their jobs, sufficiently support their own families, and at the same time focus on the critical work they have dedicated their lives to, educating and caring for our littlest residents. Thank you so much, Chairman Henderson. I look forward to answering any questions you might have.
Thank you, Ms. Perry. Rebecca Barson.
Good morning, Chairperson Henderson and Director Kaufman and members of the Committee on Health, and thank you for allowing me to speak before you today. My name is Rebecca Barson, and I am a Ward 3 resident. I am also the owner of RDB Strategies, a small health policy and advocacy consulting firm, a proud DC HealthLink customer, and a member of the DC Health Benefit Exchange Standing Consumer Advisory Board. As you consider the DC Health Benefit Exchange Authority's budget in today's hearing, I want to share with you the positive impact that DC HealthLink has had on my life and career. Just over 7 years ago, in early 2016, DC HealthLink enabled me to fulfill a lifelong dream of self-employment by allowing me to purchase high-quality health insurance that I could afford as a small business owner, something that had been unattainable before the existence of the Affordable Care Act and the health insurance marketplaces it established. And one of the reasons that I needed to ensure that I had such coverage is because I am part of the nearly half the population that has a chronic condition. Particularly, I am one of the 47 million Americans who have migraine disease. In my case, it is chronic, meaning I have more than 15 migraine days a month, and it significantly affects my quality of life. Excellent insurance coverage is essential. And I have found that through DC HealthLink. The website is incredibly informative and the enrollment process is intuitive. While I didn't need online or in-person assistance, I appreciate that these options are available and abundant. I've had coverage for the past 7 years with CareFirst Blue Cross Blue Shield, and I am grateful for their broad network of providers because I have had to see a lot of providers to get the care right for my condition. With my PPO plan, when I exhausted the options in the DC area, I have now been able to get care at Jefferson Headache Center in Philadelphia, considered the best headache care facility on the East Coast on an in-network basis. In addition, there have been a lot of new drugs and treatments for migraine in the last several years, and I have consistently had access to all of these if they have come on the market. I am in several Facebook groups for those with migraine, and people often complain about how their insurance won't cover their treatments. And I feel so lucky that I haven't had that experience. I also have coverage for complementary services like acupuncture and chiropractic, as well as coverage for mental health services, which is so important when dealing with a chronic illness. While I continue to search for the best treatments that will help me feel my best, it is such a relief that my insurance coverage isn't a barrier to these efforts. The coverage I have through GC HealthLink really is as good or possibly better than what I would have through a traditional employer. I also appreciate GC HealthLink's efforts to obtain rates as affordable as possible for their customers, so I can continue to afford this excellent coverage. Thank you, Chairperson Henderson, for the opportunity to share my experience with GC HealthLink today, and I am happy to answer any questions.
Thank you, Ms. Barson. Nicole?
Good morning. Good morning, members of the Committee on Health and Chairman Henderson. My name is Nicole Quiroga. I'm President and CEO of the Greater Washington Hispanic Chamber of Commerce, and I'm here today to testify on behalf of DC Health Benefit Exchange Authority, which manages and operates the district's online health insurance marketplace, DC HealthLink. Since 2013, GWHCC has partnered with DC HealthLink to engage, educate, and facilitate health insurance enrollment for DC individuals, families, small businesses, and their employees. To ensure the accomplishment of its mission, the Chamber has collaborated with community-based organizations, local businesses, and federal and local government entities to provide access to high-quality, affordable health insurance to members of the Hispanic community and other minorities in the District of Columbia. In the area of education and enrollment, GWHCC partnered with DC HealthLink to host the popular virtual One Touch enrollment events. Over this past year, GWHCC touched more than 400 individuals and families, resulting in 200 new enrollments and 180 renewals. GWHCC has also hosted 52 outreach and educational online sessions where our chamber touched more than 3,000 small business owners to inform them about the benefits of health insurance through DC HealthLink. Through the online networking events, our chamber was able to touch, promote, and disseminate information during several specialty events, including women's groups events, webinars, and the annual GWHCC Business Expo. Our chamber, in association with DC HealthLink's small business partners, plays a significant role in hosting DC HealthLink's annual Small Business Summit, Power Up DC, every year. As a result of various marketing, outreach, and specialty events, our chamber was able to enroll 120 new businesses on the exchange and are successfully tracking and seeking to close the goal for another 150 businesses. Our chamber will continue to work side by side with DC HealthLink and its leaders to ensure the District of Columbia individuals, families, small business owners, and their employees have access to high quality, affordable health insurance. We will continue to focus our efforts on developing creative marketing strategies for outreach, including hiring bilingual staff of all languages in the district demographic. And using bilingual promotional flyers and brochures to educate and facilitate an easy, efficient, and convenient enrollment process supporting the implementation and sustainability of the Affordable Care Act in the district. We are very proud of our award-winning DC HealthLink marketplace and respectfully request the council to continue to support the mission and goals of DC HealthLink Benefit Exchange Authority as it continues to provide DC residents accessibility, dignity, and the basic human right of health insurance coverage. Thank you for the opportunity to testify. I'm here if you have any questions.
Thank you. Che?
Good morning, Chairperson Anderson, members of the committee staff. Thank you for the opportunity to testify today. My name is Che Riddle Tabasola. I'm Director of Government Affairs and Member Advocacy at the Rest Association of Metropolitan Washington. And I'm here today to present testimony on behalf of the DC Health Benefit Exchange Authority, or DCHBX. The Rest Association Metropolitan Washington actively supports and promotes and Washington, D.C. area food service industry on behalf of our 1,400 plus members, which include owners and operators, food distributors, and service providers. Our membership diversity range of businesses, food service industry. In DC, 86% of first restaurants are independently owned and operated, meaning the majority of local restaurants are small businesses, and that includes RMW.
Jay, are you? Okay, I think he fell off. We'll stop the clock and wait until he logs back on. In the meantime, is Veronica Hernandez here? No, Veronica. Or Lisa?
Hi, this is Lisa. I'm here.
Okay, great. Lisa, you could go ahead and testify. Sorry, we had someone who dropped off. He'll be back, but in the
No problem. Well, good morning, Chairwoman Henderson and members of the Committee on Health. My name is Lisa Nip, and I'm a Ward 6 resident. I thank you for allowing me to speak before you today regarding DC HealthLink and the positive impact it has had on my life as a small business owner in DC. I have my health insurance through DC HealthLink's individual marketplace. As this is a budget oversight hearing, I want to share how DC HealthLink and the Affordable Health Care Act have allowed my family to purchase health insurance multiple times for almost a decade as my family's employment status changed. I have worked as a self-employed corporate photographer for over 20 years, and I am now a single mother after the death of my husband last year. Without DC HealthLink, I would be unable to afford coverage for me and my son. My family has been DC HealthLink customers on and off since 2015. At the time we became DC HealthLink customers, my late husband worked as a baseball analyst for Masson as an independent contractor, and this work did not include employer-sponsored health insurance. When we reached out to DC HealthLink, we were immediately offered help finding a plan. Despite not qualifying for any subsidies because of our income, we were able to afford coverage with lower deductibles at better price points as the years went on. We were very pleased with both the quality of our medical and dental plans and the customer service provided by DC HealthLink. In 2017, Masson offered my husband the opportunity to purchase health insurance through their employer plan. So we left DC HealthLink because it was cheaper to take the Masson coverage. My husband contracted a rare form of cancer in January 2020, and he passed away 1 year later. Over those 12 months that he was ill, this private plan paid out almost $5 million in healthcare expenses, but our total out of pocket was less than $1,000. During the COVID-19 pandemic, my husband's television show was canceled and he was laid off again. My photography business shut down completely. Neither of us worked during most of 2020. Masson kindly continued to allow my husband to remain on their insurance plan, but my son and I were removed from this plan in September 2020. After all I had been through dealing with insurance billing during my husband's sickness, I was terrified of being without insurance myself in case something else happened. I reached out in tears to DC HealthLink, and within 24 hours, they connected me with a person who helped me enroll my son and I in a Medicaid plan. With the passage of the American Rescue Plan Act, I received a notice from DC HealthLink about premium reductions. This notification came around the same time that my income recovered enough that I was no longer eligible for Medicaid, but I did not think that I could afford to buy a plan on the exchange. I worked with a DC HealthLink representative, and I found that I qualified for a silver level plan at an affordable $111 a month. It was such a relief to know that I had this coverage and that I could return to the doctors and other healthcare providers I had used for years. After the Inflation Reduction Act extended lower premiums from the American Rescue Plan last year, we were able to stay with the silver level plan. My income has significantly recovered, and with help from the federal monthly tax credit, I have a plan that saves me $6,400 a year. As a single parent to a teenage soccer player who spends his weekends at urgent care, our healthcare plan is always at the forefront of my mind. I have seen firsthand that good insurance prevents financial ruin during times of life-changing illness. The silver plan I have through DC HealthLink allows me to sleep at night without worry because I know that I have coverage that will provide for the care I need, a deductible that I can afford, and the support of the customer service representatives at DC HealthLink. Thank you for the opportunity to share my healthcare journey. I'm happy to answer any questions you might have.
Thank you, Ms. Nip, and apologies for your loss, but we'll have some questions for you in a minute.
Thank you.
Angela Franco.
Good morning. Good morning, Chairwoman Henderson and members of the Committee on Health. My name is Angela Franco. I'm the President and CEO of the DC Chamber of Commerce, and I'm here today to represent the member companies of the Chamber and the vast array of individuals they employ. Thank you for the opportunity to testify on the proposed 2024 budget submission for the District of Columbia Health Benefit Exchange Authority. We're pleased to support the DC Health Benefit Exchange 2024 budget as proposed, and we ask that you and the members of the committee maintain this funding as you move through the council's budget process. Sustaining the Small Business Health Options Program, SHOP, Small Business Marketplace is more important than ever to small businesses and district residents who are enrolled in coverage through DC HealthLink. We here at the Chamber value our ongoing partnership with the DC Health Benefit Exchange Authority, and we thank the leadership and staff for consistently collaborating the transparent approach that they bring to all the important work with us in order to provide coverage to our small business employees. I also want to take a moment to commend the leadership team at the DC Health Benefit Exchange Authority for keeping us informed at all times on the breach and information and what we had constant communication and see how we as an organization could support them as well. Throughout the years since the DCHBX inception, the DC Chamber has partnered with the DC HealthLink as it seeks to accomplish its mission to ensure that every DC resident, small business, and its employees have access to quality, affordable health insurance. Through virtual and in-person interactions and web-based information sessions to the small business community, we have been supporting the exchange in accomplishing its goals. From promoting the health insurance enrollment campaign during the open enrollment season to conducting presentations and sending direct emails to the DC Chamber members, informing them of the benefit of participating in DC HealthLink, the DC Chamber has been there as well. The DC Chamber heavily markets DC HealthLink initiatives and campaigns via electronic news blast and emails. In response to the lingering impact of COVID-19, we focused our efforts on helping DC HealthLink promote and provide awareness of the following programs: DC HealthLink Special Enrollment Program for uninsured employees of small business currently covered through DC HealthLink, the Small Business Premium Deferment Program for past installments and no-cost insurance coverage benefits associated with testing and treatment of COVID-19, and the Inflation Reduction Act of 2022, where residents qualify for lower monthly premiums as low as $11 a month. The DCHBX Executive Board helpfully expanded qualifying live events to include COVID-19. This action permits any current employee of a small business that purchased health insurance through DC HealthLink to enroll in their employer's health plan. We have also increased our social media promotions, the DC HealthLink programs and services through our chamber distribution to over 11,000 recipients. Plus, we have dedicated staff helping, enrolling, and reaching out to the small business community in the District of Columbia. As a result of our collaborative efforts, the DC Chamber in recent years has encouraged and enrolled over 200 of DC small businesses. Our efforts continue aggressively as we work diligently to get more businesses enrolled. DC HealthLink continues to rank in the top 3 states in the nation with lowest uninsured rates. Additionally, through their point of service with nationwide networks and local regional networks, small businesses with offices in other states can cover all their workers through these networks. We look forward to continuing to work with the DC Health Benefit Exchange Authority to improve and maintain an affordable health insurance program for the district's business and family. And I just want to conclude saying that we are extremely committed in, sending all this information to the small business community in the District of Columbia. This is critical. It's critical to make sure that they're covered. And we know that our job as a Chamber of Commerce is critical in making that happen. Thank you so much for the opportunity to testify this morning, and happy to answer any questions.
Thank you, Ms. Franco. I see that Che has rejoined us.
Hi, council member. So
Hi.
apologies.
No problem. The joys of virtual. So why don't you go ahead, because you kind of went in and out at the beginning.
Sure. Through our partnership with DC HBX, we are able to support outreach, education, and enrollment efforts to the food service community. We are able to commit dedicated staff to outreach and programming efforts that offer access to brokers who provide restaurant employers with the necessary support in evaluating their ability to offer health insurance, starting the enrollment process, making changes to benefits, and keeping their employees well informed of the available coverage options. We provide information about individual enrollment options to restaurant workers, attending our training classes. And when employer-sponsored insurance is not offered, we work with DC-HBX on initiatives such as the DC Health Link at Work initiative, which gives small businesses the choice of having a DC-HBX representative meet employees on site to inform workers of coverage options and to offer enrollment assistance. As a collective voice with DC HBX, other business partners, and community organizations, we advocate against regulations that jeopardize critical Affordable Care Act protections that would have adverse effects on our local marketplace's ability to provide quality and affordable health insurance. Additionally, we help to keep this important benefit, option, and resource in the forefront of operators and decision makers by amplifying messages during the open enrollment period, participating in events such as the popular Power Up DC Small Business Summit, integrating DC HBX into our events, our training, member-focused meetings, and through a continuous presence of DC HBX and RMW's member communications and digital assets. Small businesses have a great need for options to help them operate and grow their businesses. The efforts by DC HBX will continue to be an invaluable asset and resource in providing access to quality, affordable health care insurance options. As you review budget submission for FY24, we respectfully request that you support the DC HBX budget submission so that we can continue to work it does to ensure quality, affordable health insurance for all district residents and businesses. Adequate funding to support its outreach, education, and enrollment activities is paramount to its ongoing success. RMW pledges its continued support for the DC Health Benefit Exchange Authority and urges the council to do the same. It's what's best for our city. Thank you for the opportunity to testify today, and I welcome any questions the council may have.
Thank you. And that was very clear. We were able to hear you, no problem. I do have some questions. I'm going to put myself on a 5-minute clock just because I can go on and on. But I want to thank all of the public witnesses for your testimony today. Sometimes people wonder, why should I come testify? But it is helpful for us to know in terms of your own personal experiences with the agency, not just for performance, but also during budget things as well. So on that, I want to follow up. Ms. Perry, if you're still with us. So during performance oversight hearing, we heard from a number of childcare directors around their experience with healthcare for childcare. And I think it is one of the more innovative things to come out of DC government in a while. As you know, the funding comes from the ECE fund that OSSI transfers over. But it sounds like from your requests, that's not what you all are looking for. You just want it baked into the 4-year financial plan for DC government outside of the fund. And that's a question mark at the end. Ms. Kim, are you still here?
I'm still here. Hi
Okay.
there, Chair Henderson. Thank you so much. And thank you for the question. Yes, the initial $18 million, and Director Kaufman can speak more to this as well, but the initial $18 million from OSSI to the Health Benefit Exchange clearly is not going to be fully spent in the first year. The program is just getting off the ground, even though the agency has done heroic work to stand up a program and to begin outreach and marketing. And so we just want to make sure that those funds can be extended into the next year, because one of the challenges is that directors are afraid that they will change their health insurance or participate or enroll in healthcare for childcare, and then the program goes away in a year, right? And they feel
Yeah.
like they're back to square one. So, so to the extent we can make sure we don't lose any funds that are not spent because of lower enrollment or because the program is getting off the ground, that it can be dedicated to the next year.
Understood.
Is that
Yep.
helpful?
No, that does help. And I think we talked about this at performance, that this money is in a separate account and it's non-lapsing. To that separately, right? In another part of the budget book, the ECE fund that we're talking about, for those who are not familiar, the pay equity fund where some of this work has come out of, the mayor has proposed taking 4 million out of that fund for other purposes. And so one of the questions I will have for Director Kaufman is what conversations that they had with OSSI in terms of the financial outlook of the cost of this, that helped inform whether or not that 4 million was necessary or not, to continue on and or expand in terms of the healthcare offerings. But thank you so much, for being here today.
Thank you.
Miss Nip, if you're still here, I want to say first off, thank you so much for your testimony and for being vulnerable to sort of speak about your whole experience and sort of in and out with DC HealthLink. And from listening to your testimony, it actually became clear to me that you might actually have some advice for us, DC government, as we're about to go embark on this process of Medicaid redeterminations, having people who are no longer eligible due to income, and then the transfer handoff to DC HealthLink. When you had to make that transition, was it healthcare finance who said you should talk to DC HealthLink, or was it you had to sort of figure that part out for yourself?
No, I was actually contacted by DC HealthLink and told, hey, here's a great opportunity for you. This has passed and you should look at this and see if you are now eligible. And if they had not reached out to me, I had read about it in the newspapers. I knew it was potentially a thing,
Yeah.
But it's different when you are actually contacted by someone who says, yes, you could be eligible for this. And then when I looked at it, it was very obvious that this was the better way for me to go. When I moved to Medicaid, I lost access to all my providers who I'd had consistently over many, many years. And that became very, very difficult. So I was very excited to be able to get back onto the exchange and back in with those providers again.
Got it. Okay. That's one of the things we're or some of the questions I will have too around as the public health emergency ends. And also, I think who was I talking to? I think it was like a group of, where was I? Ward 7, a group of folks who were talking about, even if someone receives the notice, if someone doesn't proactively reach out to them, they may not go ahead and re-up in terms of connecting for another health insurance process. And so it's great to hear that DC HealthLink was the one who proactively reached out to you. And we have some questions in terms of what the process is going to be for that. So thank you for being here. Nicole, Che, and Angela, thank you so much for being here and for your feedback in terms of how we are working with small businesses and the insurance that we'll be able to provide there. So I don't have any further questions because I'm over my time and I need to be good about my time. So thank you all. And we'll move on to the next panel.
Thank you.
Public
Thank you so
witnesses.
much.
So you are welcome to stay, as in stay, listen to the hearing, but we're going to move you back into the general room. And then for those who are joining us, again, I'm just going to call up all of the last public witnesses that we have. You have to affirmatively accept our invitation to become a panelist. So Jay Yarborough, Whitman Walker Health, Floyd May, Gabriella Morgan, Marlene Cherry, Paulette Sheffield, Yasmina Castellanos, Alexandra Jelleret, and Donjel Williams. If I said that incorrectly, I hope you correct me otherwise. Okay, while we're bringing people into the room, I do see Jay. So Jay, if you want to go ahead and get started. Jay, if you're speaking, we cannot hear you. Jay, we still cannot hear you if you are speaking. I see you're off mute, but we still cannot hear you. Okay. Jay, you might have to go out and come back in. So we're going to go to Floyd and then we'll come back. Mr. May. Mr. May, I see you. If you're talking, you are on mute.
Can you hear me now? I'm sorry.
Yes, sir. All right, there we go.
Good morning. I am Floyd O'May. I'm the Executive Director of the Leadership Council for Healthy Communities, LCHC. We're located at 10 G Street Northeast in Washington, D.C. I am pleased to provide testimony at the FY23 budget hearing on behalf of the D.C. Health Benefit Exchange Authority. LCHC is an organization of clergy leaders, medical professionals, public and community leaders working together to help African Americans and other communities of color to promote healthy behaviors and eliminate health disparities. LCHC has had the privilege of serving as a sister organization of the Health Benefit Exchange since it first opened its enrollment. We have built relationships with clergy organizations, neighborhood businesses, and houses of worship that allow continuous access to residents who need health insurance coverage. We are keenly aware of the great work that the exchange is doing and how helpful they are in assisting the DC residents in assessing affordable quality health insurance through the DC Health Link. It is abundantly clear how important and worthwhile our work is in getting persons enrolled. One example in particular comes to mind when a 32-year-old woman who had less than a month to give birth reached out for enrollment assistance. With the help of LCHC Assister and the DC Health Link call center, the resident was able to obtain health insurance coverage. The consumer calling the enrollment process said, "I was 8 months pregnant when I moved to Washington, D.C. from North Carolina on a job transfer. Unfortunately, my employer does not cover health insurance. I had to look for information on how to enroll for health insurance benefits. On Google search, I found contacts through the DC Health Link's website. DC Assister and DC Health Link call center, understanding my situation, expedited my enrollment into a qualified health plan. Surprisingly, that same day I gave birth. I became eligible for my health plan. Thanks to the Almighty God and the team who assisted me, I would highly suggest DC Health Link. During the COVID-19 pandemic, the exchange, in collaboration with LCHC and other assister organizations, successfully pivoted its efforts to reach residents throughout the COVID pandemic by enrolling in health insurance after losing their jobs and losing health insurance coverage through their employers. Hundreds of calls were made to provide information and to assist people with enrolling in health coverage plans. The exchange's efforts to reach the uninsured is unending. With the passing of President Biden's American Rescue Plan Act, the exchange embarked upon a campaign, Healthcare for Child Care, to reach uninsured and underinsured child care workers to assist them with getting affordable quality health insurance. We continue to make every effort to meet these people as they are. To that end, LCHC assisters have participated in numerous outreach efforts, including the DC Metropolitan Police Department's Beat the Streets, Martin Luther King Day Health Fair, AMC movie theaters, Healthcare for Child Care enrollment at the DC Armory, as well as other health fairs and COVID-19 vaccination pop-up clinics for those consumers who, like so many others, are affected. I hope there is a steadfast commitment to DCHBX to continue the involvement of LCAC and other sister organizations. This work is done to help improve individual and community health. To quote Martin Luther King Jr., we deeply believe that all the forms of inequity, injustice in healthcare is the most shocking and inhumane. The work is solemn, task is a sacred duty. I commend the leadership staff of the DC Health Benefit Exchange Authority, and I pray that they will continue to work to lend to the success of the service to DC residents. Thank you very much for allowing me to testify, and I'm available to answer any questions you may have.
Thank you so much. Jay, are you back with us?
I am back. Are you able to hear me?
Yes, I can. Awesome.
Thank you. My apologies for the technology.
No problem.
So good morning, members of the committee. My name is Jay Yarbrough. I am the manager of DC Health Link Assistant and Navigator Program here at Whitman Walker Health. I am pleased to be here to present testimony in support of DC Health Benefit Exchange Authority and share our experiences as an sister organization. As you might know, Walker Health provides high quality affirming healthcare to more than 20,000 individuals, 4,000 of whom are living with HIV, and more than half of whom are members of the city's LGBTQ community. Women Walker Health is proud to have served the DC Health Link Assistant Organization and an encounters enrollment center for all DC Health Link open enrollments since 2013. We completed our 10th open enrollment period with our sister staff providing outreach education to uninsured and vulnerable consumers. For the past 10 open enrollments, 62% of the consumers we assisted were living with HIV and 45% identified as LGBT, both important target populations among DC's and underinsured. During the 10th open enrollment period, which just ended in January this year, we have assisted nearly 700 individuals with close to 1,400 one-on-one encounters. In addition to our regular enrollment activities, we are also partnering with DC Health Benefit Exchange on outreach and enrollment for the important initiative called Healthcare for Childcare. To date, we have connected with over 100 DC childcare employees to provide counseling about their eligibility for the DC Health Link Marketplace plan, free plan, leaving them only responsible for their cost sharing. We've assisted all who are interested with enrollment, and as a DC Health Link Enrollment Center, and all our workout team remains focused on providing welcoming, confident, affirming, and easy to access environment to help consumers understand their options, to shop and compare and enroll in affordable health insurance and programs that reduce out-of-pocket costs. For the first 2 years of the pandemic, we saw unprecedented job loss and reductions in working hours, leaving many residents losing their employer-based coverage or needing alternative insurance options. In response, DC HPX leadership immediately stepped up and prioritized outreach to those consumers who are losing coverage by connecting them to them and all individuals to an assister. We have also seen people securing new jobs or piecing several jobs together, necessitating questions about health insurance options or shifting for what coverage options for these consumers are eligible. Women Walker alone has been able to reach out to over 3,400 consumers who were set to lose their coverage through SHOP or had other questions about securing new coverage. In response to the public health emergency, Medicaid recipients will allow continuous coverage without going through annual renewal process with the passing of the Consolidated Appropriations Act. The continuous coverage portion of the PHE will be ending tomorrow, meaning that Medicaid recipients will now have to go through the renewal process, resulting in a not insignificant number of individuals likely transitioning from Medicaid to assisted or unassisted QHP through the marketplace. During this Medicaid unwinding, the role of the assister will be crucial in educating, counseling, and enrolling DC residents into a qualified health plan. Continuing assister funding is critical to ensure consumers facing challenges in their income and insurance status understand their options and have an expert to help ensure they get and maintain health insurance. Getting and keeping health insurance are a challenging task. Consumers need trained experts to understand the complex eligibility and documentation rules, successfully navigate the application and renewal process. We see firsthand everyday individuals who would not get connected to health insurance without the help of a DC Health Link assistant. And we firmly believe that with this partnership, that accounts for the district's ranking as the second lowest uninsured rate in the country. I will close with our appreciation for our partnership with DC HPX and our strong relationships with DC DHCF and ESA. I'm now opening the floor for any questions. Thank you.
Thanks, Jay. Gabriella Morgan.
Good morning.
Good morning.
Good morning, committee. My name is Gabriela Morgan. I am the Chief People Officer for Community Kids Preschool. I am pleased to share with you all this morning the impact that DC Health program has how this has been impacting in our organization as a business. Just to give you a little bit about our background, we have 6 centers. 99% of our staff members are immigrants. We are minorities. And one of the main concerns we have as a small business, it was the medical coverage. Unfortunately, we have teachers that they can afford to have access to buy medical coverage for them or their families. Last year, for say an example, we have we covered 2 territories. We have our total employees, including Virginia territory, is 132 staff members. Last year, before this DC Health, or the previous year to this year, from all our staff members, they were in our payroll system. Just 17 people could afford to pay for medical coverage for themselves. When we got we were contacted by DC Health team, we were so glad and so happy to know about this great news, this program, because that was a main concern for us as an organization, how we can provide a better compensation package for our staff members, especially medical that's so sensitive in this country. As an immigrant myself, I know how concerned my teachers were coming and working in the HR department. My teachers were telling me how concerned they were because they were so scared to get sick because they couldn't afford and they didn't have coverage. So when we started last year, we were contacted by DC Health, who has been doing a great job. I would like to take this time to also say how much we appreciate, because they have been giving us all the tools and the assistance that we need to go through all this process. It has been complex for all of us, but working as a team has been great. So thank you to DC Health Exchange team, because they have been giving us all the support. So now, since we start working, we went through the process to see we were eligible. And thank God we were eligible, because we had 2 territories, as I mentioned before. We have 5 centers in DC, 92 staff members work here in DC, and we got the coverage for them. And now, since last year, when we shared with our staff this great news about this program, we have 82 people enrolled in this great DC Health program. For us as an organization, we are contributing with doing our part as a company, as a business, as employer as well, committed with our staff. Our teachers are not paying anything for their premiums. Company is paying for their premiums. And we really appreciate if we can continue with this program, because I think It has a big impact. I can tell my staff is happy. They have that peace of mind. They are covered by this program, and they can get sick if they don't have any concern about how they're going to pay their bills. Thank you so much for all this support, and I hope we can continue working with this great program. Thank you. Have a wonderful day.
Thank you, Ms. Morgan. Do you mind sticking around so I can ask you some questions?
No, yes, ma'am.
All right, thank you. All right, Ms. Cherry? Marlene Cherry? If you are speaking, we cannot hear you. Okay, Ms. Cherry? If you are speaking, we can't hear you. Okay, Ms. Cherry, we're gonna go to the next witness, and then we'll come back and hopefully we can hear you after. Paulette Sheffield?
Ms. Sheffield,
Got it. I'm sorry about that, Mr. May. Yasmina?
Good morning.
Good morning.
Hello, my name is Yasmina Castellanos.
Yasmina, I don't know if you wanted
Yes.
us to see you, but your camera is not on.
Oh, okay, excuse me for 1 second. Let's see here.
There we go. Hello.
Hello, how are you?
Good.
Great. Thank you so much for this opportunity. My name again is Yasmina Castellanos, and Community of Hope is one of the organizations that has this great partnership with DC HealthLink. We've been in partnership for well over a decade, and I'm very proud to say that we've made a difference together in the lives of many DC residents. Our enrollment assisters continue despite the COVID pandemic and everything that's been going on in the aftermath. We've been supporting enrollment and a lot of outreach efforts to ensure that our DC residents have had coverage either in person, via telehealth, or by phone. It's been a great combination to be a health organization. One of our departments is health services, and it's been a great combination to have particularly this partnership with DC HealthLink. We have clinics in 3 quadrants of the city: Northwest, Northeast, Southwest, in wards 1, 5, and 8. And we've remained at the forefront to provide healthcare during this time, and also ensuring that we're connecting with neighbors, friends, and small businesses. We have been able to assist a lot of residents who may have been paying hundreds for their premiums, and they're now either able to pay well under the expected premium amounts, or probably just have full coverage without cost. I can give you one of the examples of the kind of difference that we make in the lives of certain individuals. We particularly, at one of our health sites, had a patient who had lost, who had a loss. They were in an unexpected tragedy where they suffered a very traumatic car accident, had been admitted for weeks in a hospital, lost employment, had no insurance, and they were, forced to face the unexpected, specialist visits, referrals, medications, therapy. And, with this said, they came to us to establish care and follow up, of course. And we were able to coordinate so much for them. We got them enrolled with insurance. They successfully were able to walk again. They were able to be on stable medication regimen and not having to deal with the stressors of being uninsured. And, we know that someone that's not insured could have very detrimental outcomes. And I think that would have been the case with this individual. So, additionally, these type of circumstances, we know come across many individuals where they don't know which direction to take. And having this partnership has allowed us to really emphasize the importance of making sure that our residents are ensured that they're visiting their providers, that they're taking care of themselves. So, our existence allows for these DC residents to have many options, resources, and of course, some direction, as my colleague Jay said earlier. It's super important for our residents to know how to navigate a system, and it's not easy at times. So we're a vital source in the community, and we ask that you please continue to fund DC Health Exchange for the greater good of our residents and for their overall health. Thank you for this opportunity.
Thank you, Yasmina. Alexandra?
Hi.
Hello.
Hi, how are you?
Good.
Good morning, Chairwoman Henderson and members of the Committee on Health. My name is Alexandra Jelleret, and I'm co-founder of Say Networks. I'm pleased to offer my testimony before you today regarding DC Health Link and the positive impact it's had on our small business as well as our employees. Say Networks is a DC CBE company. Say Networks specializes in health technology, and we provide services in health quality improvement, Medicaid consulting, virtual health, web and application development, staffing. Our company is headquartered on Good Hope Road in Southeast DC, and our employees work out of the office remotely and in some hospitals and healthcare settings as well. We have been a DC HealthLink customer since 2018. We offer our employees coverage at all metal levels through United Healthcare. This way they can choose a plan that best fits their needs. Because we work in the health technology sector, providing our employees access to quality, affordable health insurance coverage is important to us. Beyond that, providing these benefits to our employees helps us as a small business. We can compete with larger firms for high quality employees because we offer great benefits through DC Health Link. We are also able to show our team how important they are to us by offering quality healthcare insurance. Because this is a budget oversight hearing, I'd like to add that offering health benefits through DC Health Link helps our small businesses' overall budget as well. Offering health insurance through DC Health Link greatly improves employee retention, which means less money spent on recruitment and training. On top of that, if a team member gets sick, they can receive treatment from a doctor and return to work more quickly. Before we became DC HealthLink customers, we provide our employees a credit so they could purchase health insurance. However, this did not always mean that our employees got coverage. Having to purchase insurance on their own was a daunting and often frustrating experience before the Affordable Care Act. As a company, we're proud to offer benefits through DC HealthLink and feel so much better knowing our team is covered. The DC HealthLink portal is easy to use, and our team has had great experiences accessing their benefits. Also, as a small business owner, it gave me peace of mind to know our employees had the coverage they needed during the pandemic. The past 3 years have been stressful for everyone, and having great quality health insurance coverage meant that our team had one less stressor to worry about, and that makes us feel great about DC HealthLink. Thank you very much for the opportunity to share my experience. I'd be happy to answer any questions you may have.
Thank you. Ms. Cherry, are you back? And can we hear you? Ms. Cherry, if you're speaking, we can't hear you. Still can't hear you. Okay. We're going to try Donjel Williams.
Hello, can you hear me?
Oh, wait, who's that? Who?
That's D'Angele.
Oh, D'Angele. Okay, great. Yes, I can hear you. I cannot see you if that was your intent.
No.
Okay, great.
Good morning, Chairwoman Henderson and members of the Committee on Health. My name is D'Angele Williams, and I am one of the administrators and teachers at Children of the Future Child Development Center. Thank you for the chance to testify before you today and share the positive experience that we've had with DC Health Link and what a godsend it's been for us. We're a small child development center in Ward 5. We currently have 3 to 5 full-time teachers, including myself, and the capacity for about 20 students from 6 months to 5 years old. Because we're a smaller facility, we rely on the strength and dedication of our teachers for our child development center to succeed. We definitely need to support our teachers in any way that we can, because in a center our size, having healthy teachers is very critical. We're around kids all the time and they're often quite sick. So when a teacher is out because of a sickness for any extended period of time, it's always a big challenge for us to overcome because we're a small staff. As I said earlier, the program has literally been a godsend for us because in general, teachers aren't paid as well as other professions. And I know myself, as well as some of our other teachers, wouldn't have health insurance coverage at all if it weren't for this program right now. So now we have peace of mind knowing that our health insurance coverage is there if we need it. Personally, I'm more confident in my ability as a teacher because I don't have to worry about getting sick and having to be out without access to healthcare. And on top of all of these benefits, healthcare for childcare is responsible for a huge morale boost at our center. As a team, we're a lot happier now that we have health insurance coverage and peace of mind to remove that worry so that we can focus on our most precious resource, which is the children. So thank you for your opportunity to share my experience, and I'd be happy to answer any questions if you have them.
Thank you, Donjale. I'm going to try one more time for Marlene Cherry. Okay. All right. Well, thank you so much to all the public witnesses for testifying and for providing some great feedback in terms of the work of the Health Benefit Exchange. And Mr. May, I want to say thank you so much for sharing the experience of the young woman that you talked about. To be approved for your health insurance the day you go into labor is like divine timing, especially sort of knowing what it costs to give birth in this country. And so that's just fantastic and excellent. I wanted to see, though, if you wanted to speak a little bit more in terms of the outreach component. And similar to what I asked someone on the last panel, you know, we're about to go through this transition period of a lot of individuals who are going to be in the midst of, I would say, upheaval and uncertainty in terms of their health insurance as we do Medicaid redeterminations. In your opinion, from the communities that you work with, what more can we be doing to make sure that folks don't fall off in the process?
Well, thank you for the question. We have over 19 churches in our network. And so all of our programs are filtered through those churches and those ministers. And the assisters are constantly engaged because of the referrals we receive from the churches, as well as the outreach workers and the people who just show up looking for assistance. And so we need to be assured that when we have these clients that have come to us for assistance, that once we make the referrals, that there will be a warm handoff and a receptivity to receiving their situation for assistance.
Got it. I think that's absolutely right. We hear from a lot of folks all the time that, you know, they're prepared, but if you have to wait 48 hours for somebody to call you back, or you never get a call back, that's where we have the disconnects in terms of the work there. So thank you for that feedback and for your being here. Yes. Ms. Morgan, thank you so much for sharing the experience of your employees over at CommuniKids. I have several friends who attend some of your locations and they love it there. And they rave about it. And so the idea that, you know, this healthcare for childcare program has been able to offer health insurance. I think you said before this program, only 17 people could afford coverage. And now I think you said you're up to 82. I'm curious, though, for the individuals who haven't, because I think you mentioned that you have, you know, over 100 employees. What if any, are the barriers to them signing up for coverage? Oh, you're on mute.
Sorry.
No
I'm
problem.
sorry. Thank you, ma'am. Yes, community preschool, we have 6 centers. One of our centers is in Fort Church, Virginia. And
Okay.
yes, the rest of the other 5 centers are located in DC. We are about to open in a new center this year as well. But the impact that answering your questions is the impact that this has been, yes. Previously, we had just 17 people. Most of these people, they were enrolled in our previous plan. It was admin team people. It was just a few teachers. I can tell maybe it were just around 6 or maybe 5 teachers they were paying for the coverage. But since we got into DC Health program, they enroll, most people were enrolled, interested in, we enrolled in this program, which has been for us as a business organization, has been really a big impact because it's from the business perspective, is it has been easy for us to hire and to retain because of this.
Yes.
Medical coverage in United States, in our country, is very sensitive topic. Most teachers that we are part of our staff, 99% of our teachers are immigrants. They come from different countries. 95% are females. So they were concerned, and that was one of my department concerns as a Department of Human Resources, is what we can do as a company, talking with the board and our organization, how we can help to providing affordable medical access.
I'm curious, Ms. Morgan.
Yes,
So
ma'am.
you have 5 centers in DC and 1 in Falls Church. Is this causing some tension amongst your employees in terms of who has access versus not?
Well, no, because territories are different. It's something
Okay.
that we explain to them. Of
Okay.
course, that costs a little bit, like everyone wants to come and work in DC. But I think it's actually good because DC is being a pioneer and not just paying the best salaries for early childhood educators, but also is leading how we are projecting to the rest of the country, which is really great. And I think the impact is putting a lot of pressure on the other side of the borders in between DC and Virginia and DC and Maryland as well, because they, in order to be to keep retain their staff, because otherwise they are going to come here. Of course, they will have to make adjustments as well. So we are waiting for Virginia to see what we can do together and offer to our educators as well in that territory.
Okay. Well, thank you so much for being here. And thank you again to all of the public witnesses. To Marlene, Cherry, if you want to submit your testimony for the record, we would most certainly like to hear that. I'm fortunate that the technology didn't allow for you to present it live with us. But that concludes all of the public witnesses that we have for the Health Benefit Exchange Authority. And I'll say again, for those who weren't able to testify, you can certainly submit written testimony for the record, and I'll give those instructions at the end. We're going to call up the public. We're going to call up the government witnesses, both Director Kaufman as well as Diane Lewis, who's the chair of the board. They have a presentation that we need a little bit of time to set up. So we're going to take a 5-minute break, and then we'll be back with the testimony from the director. Thank you.
I just turned the mic on.
Great. Wonderful. All right, and we are back. We have Mila Kaufman, the Executive Director of the Health Benefit Exchange Authority, who will provide testimony. She has a presentation, which is up on the screen. But before you begin, ask you raise your right hand. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth? Great. Please begin.
Thank you. Thank you very much, Council Member and Chairperson Henderson. And I just want to introduce with me, I have our Executive Board Chair, Diane Lewis, as well as Marjorie Edmonds, who is our Agency Chief Financial Officer, to answer any questions you may have that I'm not able to answer. And so good morning and thank you for having us. And thank you for all of your support for the Affordable Care Act and for the Health Benefit Exchange. First, when you were a staff person here at the council back in 2013, and certainly through the recent years as an elected official, as a council member, and currently as chair of this committee. So thank you. As a way of background, the DC government established us to implement the Affordable Care Act and specifically the state-based online health insurance marketplace called DC HealthLink. We were one of 4 state-based marketplaces to open for business on time on October 1, 2013. We cover approximately 100,000 people with private health insurance. That includes more than 80,000 people through our small business marketplace, which includes approximately 5,300 district small businesses and nonprofits, congressional enrollees, as well as DC residents and their families. We're responsible for more than $670 million in annual premiums. And since we've opened, we've helped to cut the uninsured rate in half. So now more than 96% of DC residents have health coverage. DC ranks number 2 in the US for the lowest uninsured rate, right behind Massachusetts. We offer robust health plan options for employers and residents from all the major insurance companies. And I just want to note that our standard plans are designed in a way to make access to essential care affordable. So there are no deductibles that are in our standard plans that apply to primary care or specialists, including mental health and urgent care and generic prescription drugs. And in recent years, we've redesigned our standard plans to be equity-based, which means that for conditions that disproportionately impact communities of color in the district, we eliminate cost sharing, and we started with type 2 diabetes this year. So insulin is free, lab work, eye and foot exams, as well as supplies and other medication, no copays, no co-insurance, and no deductibles. And starting next year, we've reduced copays for pediatric mental health to $5. As you heard earlier, we're also responsible for healthcare for childcare through DC HealthLink, which helps OSCE licensed early child development facilities provide affordable health insurance for their employees. And right now, free premiums and lower premiums are available for all of 2023. In terms of our budget, our process is first, the staff develops our budget, then we seek input from our board finance committee, then we seek input from our standing advisory board, and then our full board votes on our proposed budget in November. We continue to leverage other DC government agencies to achieve efficiencies. We continue to phase out consultants and transition more work to FTEs, that means employees. And we've been able to reduce some of our operational costs through our partnership with the Massachusetts Health Connector. For FY24, our proposed budget is approximately $37.5 million. And funding for that comes from primarily an assessment on all health carriers, which is projected to be 0.82% that is under 1% at 0.82%. And that should yield approximately $36.1 million in funding. We will receive $1.3 million from the Massachusetts Health Connector for reimbursement, and we anticipate about $100,000 from investment income. So that's the funding sources for our budget. I'm just going to skip through a bunch of these slides. I want to make sure that I fully discuss how what our budget is spent on, how we're organized. So essentially, our proposed budget for FY24 by program area, as you can see, most of our budget funds are marketplace operations, we call MIPO, as well as our IT. And I'm just going to walk you through the non-personnel costs in our budget. So our operations division runs our contact center, and that includes our vendor agreement to operate the contact center at $3.5 million. That includes expenses for our Salesforce licenses and other licenses that the contact center needs. Our marketplace operations also includes eligibility and enrollment, and the non-personnel budget is $463,000. That includes a small MOU with the Office of Administrative Hearings. They handle all of our eligibility appeals. So when someone is denied APTC or they believe that they should qualify for higher advanced premium tax credits, those are the kinds of cases that the Office of Eligibility and Appeals handles. Our plan management includes a budget for actuarial services. As you know, we advocate for the lowest possible health insurance premiums every year for all of our customers. We hire external actuaries to analyze the proposed rates that are filed with the insurance department, and our external actuaries also assist us in testifying every year, advocating for the lowest possible rates when the insurance department, when the insurance commissioner holds hearings. Our plan management budget also includes what we call plan match. That's anonymous shopping and doctor directory and a formulary lookup tool and other consumer decision support tools. As you heard from one of the witnesses, we have award-winning consumer decision support tools. And so our plan management division, the budget for those tools are in the plan management division. Our small business marketplace, non-personnel, is budgeted at close to 900,000, and that includes a bunch of elements. Specifically, the largest is premium aggregation. What that is essentially when an employer signs up and offers coverage, let's say from all insurance companies at a particular metal level, the employer gets one bill from us, and we pay the correct amount to each insurance company that the employees choose. And so that function is called premium aggregation. And I'll note, as a result of our partnership with the Massachusetts Health Connector, we are able to reduce our budget for premium aggregation to a little over 500,000, and that's a savings of about 320,000 a year. Performance management is where we put everything else for our operations division, which is computer refresh and postage and shredding and things like that. Consumer education and outreach, I wanted to also spend some time on this. We're budgeting at 3.3 million, which is slightly higher than FY23 budget. For the non-personnel services, that includes enrollment outreach, which is critical to our success. You heard from our business partners, all three chambers, the largest chambers in DC. You heard from our sisters, and these are the folks, the trusted voices on the ground that help reach people and help them find out about DC Health Link, and also help get folks enrolled, employers as well as their workers and individual residents and their families. So that is a critical budget investment for us. And it's for the FY24 budget, it's slightly higher than FY23 budget. Marketing and outreach is also critical. This includes our paid advertising, and it's a critical way for us to make sure that DC-wide employers and residents are aware that they can get affordable quality health insurance through DC Health Link. Our IT budget is slightly higher than FY23. So for the non-personnel services budget, it's at 7.4 million, which is slightly higher than FY23. Most of that is for IT consultants at 5.1 million and software at 1.6 million. We do invest additional approximately $500,000 to make sure that we have additional resources when we do major deployments. And that's to ensure if major IT deployments result in any kind of technical hiccups, that we have the staff to address those very quickly. The rest of IT budget is licenses and services that we reimburse Octo for, as well as administrative costs such as computer refresh. Agency management program includes a bunch of work that we budget to do with other agencies. As I mentioned, we leverage the expertise of other DC agencies, so we don't duplicate services, but we leverage other agencies to help us perform certain things. For instance, we have an MOA with DCHR to help support our HR services, and we have an MOA with DISB. They do our assessment. They send out notices to health carriers every year for us in terms of the assessment that a particular health carrier owes. We also have an MOA with the Contract Appeals Board and to provide us with services should our procurement decisions be challenged. Agency financial operations is relatively stable, and we essentially fund 3 FTEs, a small but mighty team, I would say. And the budget for that is relatively the same as FY23, which includes a payment for a variety of financial audits that we are required to do. And just to close this, I just want to thank our entire HBX team for making sure that we deliver services efficiently and are able to serve all DC HealthLink employers and residents who need affordable health insurance coverage with the highest degree of integrity and quality. And as you heard from many people, with great speed to make sure that people who need coverage get it quickly. And with that, I'll conclude by saying we appreciate all of the national awards we've been recognized with, including several years being ranked as #1 for our consumer decision support tools, as well as being recognized by Amazon Web Services, City on the Cloud, international awards for our work on best practices and innovation in IT. And with that, Madam Chairperson, we're happy to take any questions you may have.
Great, thank you so much. So this is a budget hearing, so I'm going to start with the budget. So I'm glad that you have your AFO here. We'll start with the slight increase in the assessment rate for FY24 from 0.8% to 0.82%. Can you tell us sort of at a high level how those assessment rates are calculated and what goes into determining the new rates each year?
Yes, so I just want to note that 0.82% is just a projection. We may adjust it later this summer. So every year in the spring, a report comes out, and DISB actually analyzes the report for us, where the health carriers report their prior year premiums, aggregated premiums. And so based on information that is submitted by the health carriers every spring, we figure out how much the premium base is. We look at our assessment budget that's approved by the council, and we make an adjustment to what the actual assessment rate is. And so 0.82% is conservative. It may be adjusted down, or if the premium base decreased, which I don't think it has, because premiums go up every year. The 0.82 may be decreased. Last year, our projected rate, I think, was 0.9% or close to it, and we decreased it to 0.8 based on the final reports.
Great, that's helpful to kind of understand that it's a projection and not a final. But even still, when I look back in your presentation around where the assessment rate was and say FY16 to now, it has gone down each year. Can you tell us a little bit more about the partnership that you all have with the Massachusetts Health Connector? When you talk about savings from that partnership, do you mean the total budget reflects HBX providing that service, and they're reimbursing? I'm just trying to, I guess, decipher a little bit in terms of the words you're using there to describe that.
Yes. So essentially, the Massachusetts Health Connector pays for 6 FTEs, and that's approximately $800,000. That's salary and fringe. Okay. That's complete reimbursement, which is in our budget, but they reimburse us for. And also, they reimburse us for a portion of our contact center costs, as well as any mailing and postage that we do of required, federally required notices, as well as cloud security, for example, and other IT work. So we built in the costs of those services into our budget, and then they reimburse. In addition to that, they pay a small administrative fee to us. And so for FY24, we expect that to be around $237,000 as an administrative fee. And I should note that there are other indirect benefits to us through this partnership. For example, when Massachusetts invests in IT development work for the businesses who use the Health Connector. And if we want that same IT functionality, we get it either for free if it's a complete match to our code, or we just pay marginal improvement modification to actually deploy it in our code.
Okay.
So there are those kinds of benefits as well. And finally, I'll note that for most of the IT support for the Massachusetts Health Connector, we use DC CBEs to do the work. And to date, we've spent more than $14 million, meaning Massachusetts paid for more than $14 million that DC CBEs directly received through this, through doing the IT work.
In your presentation, you broke down a little bit in terms of the consumer education and outreach budget. You mentioned that enrollment outreach, I think you have about $1,050,000 that's budgeted. That is an increase over FY23. Approximately how much increase is this?
It's about 50,000
About
increase. Yeah, just to adjust for some cost of living, a little bit of inflation. But it's essentially the whole budget is for our assisters as well as our business partners. That line item you're referring to.
Okay. So I guess, sort of follow-up question to that is, obviously with the outreach associated with the public health emergency ending, that's FY23, but I imagine because we're doing this in phases, that you might see some increased costs in FY24. Do you believe that you have, well, two questions. One, do you believe that you have the adequate resources for what is coming this summer in terms of the outreach efforts that you all are planning in connection with Department of Healthcare Finance? So I'll start there. And then two, do you feel this is a sufficient number to sort of carry us into FY24?
Yes, and yes. Okay. So we're backing up essentially DC's Medicaid agency in their outreach. And the way we traditionally use our assisters, we prioritize what they work on depending on new federal laws. For example, you heard about the Inflation Reduction Act and the American Rescue Plan. So instead of just doing general outreach, talking about, qualifying life events, after open enrollment, you can still enroll. We really are very strategic in how our sisters focus their time. And so in this case, we are planning to focus a large majority of the sister time on Medicaid unwinding and helping us catch people who no longer qualify for Medicaid because they're no longer eligible. And in fact, we're also making sure that at our contact center, we have staffing levels similar to what we had during open enrollment.
Okay, that's great.
So we can use our contact center as well to reach out to people who are no longer eligible for Medicaid, maybe because of their income, for example. This is very similar to what we've done before the public health emergency. When someone lost their Medicaid, for example, because they weren't eligible, our contact center would call them.
Okay. So you already have that agreement in place. And I think one of the public witnesses sort of talked about this, where healthcare finance is providing you all some sort of list to say, here are the list of individuals who we have determined, this is even before the redeterminate, since we've been doing this for a while, to say, here's the list of individuals who unfortunately no longer qualify. We've provided their information to you, but it would be great if you all can proactively reach out to them as well.
Yes, so we did this on a regular basis before the public health emergency.
Okay.
Where we would get monthly reports. And with the unwinding, in fact, it's even a more formal arrangement where Department of Healthcare Finance will be providing us with a monthly report.
A monthly report.
Correct.
How many people do you anticipate? I know obviously we're not doing everybody at the same time. They're doing it in sort of chunks. But is there a capacity limit that you all have of saying like, don't send us 15,000 people, you know?
I just want to say how appreciative I am of the Medicaid director, Melissa Bird, and Deputy Mayor Wayne Turnage, their approach on unwinding.
Okay.
The district is taking all allowable federal time to do this in a very measured and thoughtful way. So it's not like some other jurisdictions where they're making redeterminations all at once. They're staging this and taking the 12 or 13 months allowed under the federal guidance. So we very much appreciate that because that allows us to also do this in a very intentional way and making sure that we have the resources for the entire Medicaid unwinding period.
Okay. But you have some flexibility that should say, your call center say, we need additional supports. We can make those staffing adjustments.
Yes, so we make staffing adjustments at the call center pretty regularly.
Okay.
The only consideration really is the council approved contract. So we're mindful that we don't exceed the ceiling.
Right. That's great. Be mindful.
But we can make staffing adjustments at the call center. And because we were anticipating Medicaid unwinding with the end of the public health emergency, we wanted to make sure that the staffing levels that we had during open enrollment, we continue to have.
Right.
Because it's really hard to recruit people who without any expertise and train them up quickly, you know, to handle an influx in enrollees who may need help from the
Okay.
call center.
And we see that that's reflected in the data. We asked in the pre-hearing questions around what has your call volume been in the last 6 months, and we have seen an uptick as well as associated wait times with that.
It's still the average is a few minutes wait, which is way
Right.
Yes.
Let me clarify, because when some people say wait times, right? Like I know, not you all. There's some folks, if I'm calling to get, say, a pediatrician appointment, I can be on hold for a smooth 20 minutes before I talk to someone. And so that's not what I'm suggesting here at all.
Yes, thank you. And airlines, especially 45-minute waits. So that's not our average.
Okay.
I do want to just clarify something. So at the contact center, there was some miscommunication. So I think 3 or 4 customer service reps that worked during open enrollment somehow got dropped, but they're back on. And so the staffing level is now at relatively the same as we've had during open enrollment. I just wanted to make sure I clarify that.
Great. Can you tell us more about the $6,000 MOA you all have with the Office of Administrative Hearings for eligibility appeals? Is this an increase from current year, or is this consistent with where we are right now?
It's pretty consistent. I can just look at FY23. They handle appeals for eligibility. As I mentioned, if someone gets a determination that, let's say, they're not eligible for advanced premium tax credits, or if they are, but the consumer believes that it should be higher. So those kinds of appeals are handled by the Office of Hearings.
It's so funny as we go through these hearings, when every agency is saying, oh, that goes to the Office of Administrative Hearings, I think about our AGLA, like our judges over there at Administrative Hearings in terms of the level of specialty that they have for medical appeals, employment appeals, workforce appeal, like housing appeals. It literally covers the gamut. on that front. But
Yes, and we appreciate their expertise on our issues. We have the amount for last year.
I guess the other question I would have is approximately how many eligibility appeals are sent to them? 6,000 seems low.
Not many. I will
Okay.
have to get you the data, but not many. And they do an annual report to council on how many appeals they hear for us.
You know,
So
these annual reports are stuck in executive purgatory. So that's what
I can forward to you the last annual report
Okay.
to give you a sense, but there aren't very many appeals.
Okay. Okay. I want to ask about a Budget Support Act subtitle that wasn't under you all, but I think impacts you. So the mayor has proposed a Budget Support Act subtitle entitled the Office of Chief Technology Officer Amendment Act of 2023, which would apply to all DC government agencies, including independent agencies like HBX. It would require, well, actually, I don't have the specific description. You're familiar with the subtitle.
Yes.
Okay. How would this impact you all in terms of how you interact with all of your other IT requirements under the Affordable Care Act and its implementing regulations?
So I just want to say a couple of things. One, we fully support the strongest possible security posture for district-wide as well as for ourselves. And we appreciate all the work that OCTO has done to assist us over the years and especially recently, and appreciate their expertise. Our technical people are having discussions with OCTO to understand how this would help us as an independent agency and how the new framework would impact all the existing requirements that we have federally. But we look forward to working with the experts at OCTO on this and to further understand how in practical ways it will work.
Okay, good. So if something arises in the next few weeks in the conversations, if you could let the committee know if there might be a conflict or something or not. I've been having conversations. Well, I don't even know if I refer to her as the chief technology officer anymore, but the former, the current, the interim, whatever, Lindsay, our CTO, around the cybersecurity needs of DC government overall, and our need to sort of have stronger standards in place that also cover some of our quasi-independent agencies as well. So, you know, it was the very first, I think, subtitle in the BSA. And so we just would love to get some feedback on that. Now I want to switch to talking a little bit about plans offerings. I was excited to see that 5 of the small group plans had lower premiums in 23 than 22. When will you all know in terms of the average change in premiums across all plans in the small group marketplace?
So the proposed premiums are filed with the insurance department, usually in May.
Okay.
And then those proposed rate filings go through a high level of scrutiny by the insurance commissioner and her team. We also have external actuaries we hire to look at those proposed premium rates and help us understand what's justified actuarially and what's not justified. And every year, usually at the end of August, sometimes early September, we testify before the insurance commissioner advocating for either no increases or the lowest possible increases, both based on actuarial analysis of our actuaries as well as public policy reasons why rates should be suppressed or kept low. And usually the insurance department finalizes their rates sometime in September. So that's when we'll know what the final rates are for 2024.
Let's talk a little bit about provider networks, and we've talked some about this in terms of the work. I was excited to see the cost sharing for pediatric mental health and behavioral health services. We've been having this larger conversation with both DBH, healthcare finance, et cetera, in terms of getting more providers to accept the insurance offerings that we have here in the district. At this intersection, if we expect the lower cost sharing to increase demand for these services, do you believe that we have sufficient providers to accommodate that increased demand, or are we going to see some issues there?
Physicians and other clinicians, providers for pediatric mental health and substance abuse and behavioral health is a nationwide issue. It's not specific to DC. Our focus in modifying coverage design was really to eliminate the cost barrier. The issue and kind of the challenge of having sufficient provider networks is something that transcends us. It's pretty much if you have large group coverage or small group coverage through us or individual coverage, provider networks is just having sufficient provider networks for the types of services you cover is just it's an ongoing challenge, and we welcome the opportunity to work on that. Periodically, we do work with DSB on looking at the provider network issues. So we look forward to it and definitely are willing partners to work with other agencies and our carriers on networks. I also want to say that one of the recommendations from our social justice working group that our board chair, Diane Lewis, also chaired, was to make sure that not only do you have sufficient networks, but that the providers in the network look like the patients they serve. And that is also an ongoing challenge everywhere, including here. And a lot of that stems from traditional institutionalized discrimination of who gets into medical school, who doesn't. And so that's also a larger challenge that we look forward to continuing to work on with our health carriers as well as other city agencies.
Yeah, as I asked that, I know it's sort of beyond your scope, but frankly, we're asking everyone this. A couple of weeks ago, my staff and we had this very long conversation about something that we were trying to do to expand coverage, but we had to sort of ask the question, if we take away the cost barrier and expand coverage, but then no one accepts your insurance, it's like a false hope that, wow, this is now covered, but like nobody takes my insurance on this, or I can't find a provider to get the care that I know I'm covered for. And how does that work for residents in terms of how that makes them feel? Or even if you're covered, are you able to get the services that you need and the time that you need it in? And behavioral health is one of those things where we've really struggled in the city, especially because given the dynamics of healthcare, we have a lot of providers who can make more money never accepting anyone's insurance in these spaces particularly. And so what does that do in terms of access and limits? So let's talk a little bit about healthcare for childcare. As I sort of alluded to with the public witness testimony, I wanted to ask you, in this budget formulation process, did you all have conversations with OSSI around what you feel like the healthcare for childcare costs will be over the next 4 years in terms of how they made some determinations around spending money out of the fund? So I believe you have 18 million. How much have you all spent thus far out of that?
Very little. And I can get you the precise dollar amount, what the
Okay.
burn rate has been. It is our first year
Right.
operationalizing it, and we all assumed that it would not be at full capacity, meaning we wouldn't have 100% of early child development OSCE licensed facilities enrolled. And so we're really happy with our enrollment so far.
So
And
how many of the centers do you have now?
so we have, and this includes our April 1 groups.
Okay.
We have 136 facilities out of the 394. So that's about 35% or so of eligible facilities. And that includes, we have about 33% of eligible residents, DC residents who work in OSCE licensed facilities, including homes, expanded homes and centers. So we have about 260 of the 790 DC residents. So it's about a third. I can tell you, so in terms of actual employer groups, we have, that equates to 90 employers. 47 of those are newly insured. And 39 of the 90 did offer coverage through DC HealthLink before, healthcare for childcare. But what we're seeing with those who offered coverage before is that their take-up rates are going up. So employees are now enrolling in health insurance, whereas before some of those employees couldn't afford their share of the premium. So there's also benefit, even though you've offered health insurance before, you're seeing more of your employees actually enroll. But I will follow up with you with the actual amount that we've paid so far out of the 18 million. And I just want to be clear, 18 million is in a segregated account for the sole purpose of paying for health insurance for OSCE licensed centers and homes, early child development.
Okay. If we could get a little bit of that breakdown, I think that will help maybe hopefully quell some of the anxiety that some in the childcare sector may have around whether or not this program is going to continue. Because obviously, I've learned many years in government, when you give someone a benefit, it's really hard to take it back when they get used to it, even if it's only been available for a year or 6 months or whatever, right? We're having that conversation now as we're sort of unwinding on the COVID centers. The number of emails that I get from people around, they still want the free tests. They still want other COVID centers open, even though it was all supposed to be temporary, but we've had it, around for a while. And so, as we saw when we did the pay raises for childcare centers, there was a hesitancy at the beginning of people to sign up because they wanted to make sure that it was real. And I think now, 136 facilities is fantastic. And hopefully those folks are talking to other folks. I just don't want us to run out of money if more people decide to opt in and take up this option, which is an excellent benefit that you can offer, your employees.
Yes. And so we have had conversations with OSCE about next fiscal year. And they're committed to continuing to fund healthcare for childcare for FY 2024. So that will give some folks more peace of mind that, come on in, enroll your employees. It's not going to be, a bait and switch. You're going to have it for, it's not only this year, but next year as well. So we have had those discussions with OSCE.
Okay. In your pre-hearing responses, you mentioned ongoing meetings that you're having with healthcare finance to coordinate the public health emergency unwinding. We talked a little bit about this, but how often are you meeting? Is it like a cluster approach where it's, you guys, healthcare finance, DBH, DC Health, or is it just the one-on-one conversation you're having with Medicaid office?
Correct. It's my team having group conversations with DHCF folks together. And I should say, these are the folks who are actually doing the work. And so it's very detailed conversations about what we need, what they need, and kind of on where the rubber hits the road type conversations.
The thing that I think gives me a little bit of confidence in this is that you all were doing this work prior to the pandemic anyway. The handoffs, people's incomes change and fluctuate. So like there are already folks even before the pandemic who, all right, you got a new job, you got a promotion, you no longer qualify for Medicaid. So let's transfer you on. I think for me, one of my biggest heartburns in all of this is that I love the fact that we are number 2 in the country in terms of health insurance coverage. I don't want us to lose that because of people falling off in the gaps of as we're sort of going through this process.
Can I add? Yes, and that also keeps us up at night as well, people falling through the cracks. So part of this population, and I'll definitely defer, to DHCF when they share this information with you or talk about their plans, but some people will no longer qualify for Medicaid here because they've moved. They're just no longer residents. Some people work for large employers and their incomes are such that they just don't qualify anymore. So those are not the folks we're worried about, right? We're focusing our attention and resources on folks who lose Medicaid. They're still residents and they lose Medicaid because their income is over the limit. We want to get those folks covered through us. So that's primarily our focus.
Yeah. I have one last question around some of the work that the great work you all have been doing around equity-based benefit design, in particular, the launch of the work that you all are doing around diabetes coverage and coinsurance. Starting in January of this year, standard plans covered type 2 diabetes care, including insulin, lab work, et cetera, et cetera. We know from the data, the number of individuals in the district, particularly in some of our communities on the east end of the city, have very, very, very high numbers of individuals who have diabetes. How is it going thus far? It's only been, what is it? Oh, it's not even April yet. So it's been 3 months. How's it going in that 3 months? I don't know if you all have received any feedback in terms of how it's working for beneficiaries.
So we're not going to know how well it works for a couple of years, essentially. We've asked our health plans to study this benefit design and to tell us, are people with diabetes adhering to, the doctor's orders now that the financial barrier is removed? Will carriers see better adherence and also really better outcomes for some people? Because if you're skipping your insulin or cutting insulin and your blood sugar goes up, you may end up in the hospital and all sorts of other implications. So we've asked our health plans to actually study this benefit design and help us understand, does it make a difference to eliminate the cost barrier completely? So we won't know for a few years how well it's worked as an intervention.
Is there anything else you guys are currently working on? It seems like you're adding something new every year. What else is on the list?
We did do one thing kind of at the same time, and that was with regard to algorithms. And we've just kind of begun that process. And that's also being viewed, obviously, nationally. But one of ours addressed the issue of kidney disease, again, an issue that significantly impacts communities of color and same communities that are impacted by diabetes, and they're related, obviously. And the algorithm is one that determines the functioning of a kidney and of kidneys. Up to this point, the algorithm separated Blacks from whites in terms of what the determination was made. And there was an overestimate of how well the kidneys of African Americans function. And as a result, we were in a position where African Americans didn't get the access that they needed or the services that they needed in a timely fashion. And so our group, the working group, looked at that and really began to talk to their providers. Now, again, it's another one of those things where we don't have total control over that. Labs make those determinations. Doctors alone don't make those determinations. But it was important that we started to raise those issues. The Kidney Foundation was also looking at those issues, and so at the same time made those decisions. What's important in terms of the more immediate result is if you go to your doctor right now in the District of Columbia and they ask you for your lab work, if you stop and take a look at it, you'll see there's only one determination on your kidney function, no longer two, and that will go for everyone. And so the algorithm that had a built-in bias with regard to African Americans no longer exists. And so we thought that was pretty exciting and an important effort for African Americans in terms of being able to receive the appropriate care they need, and for a disease that has serious implications for life and wellness.
Yeah, that's great. And the implications that it has for everyone.
Yes,
which
absolutely.
is fantastic.
Absolutely.
Awesome. Okay, give me just 1 minute. All right, I don't have any other questions. And just checking online, I don't see any of my colleagues, right, Ashley? Okay, so this concludes my questioning. Director Kaufman, I'd like to thank you as well as Ms. Lewis for being here today and providing testimony and information to the committee. If you can send the breakdown in terms of the spending as a follow-up on healthcare for childcare, I will take that information, take it to the committee of the whole hearing. Well, I'll talk to Asi about that. So for anyone who is not able to attend and speak at today's HBX hearing, we will accept public testimony until April 13th at 5 p.m. You may submit written statements to Ashley Strange at astrange@dccouncil.gov, or you may leave a voicemail at 202-430-6046. If you do leave a voicemail, please remember to speak slowly and spell your name for the record for our transcription. So we will take a 5-minute break before transitioning to the United Medical Center. And they're here, and I think there's only one public witness for that. So we'll be back. Yeah, right around 11:16 or so, and then we'll get started with United Medical Center. Thank you so much. I thought I was answering different questions, so I never came back, but thank you for sitting here. Right. Okay, and we're back. We will now move on to United Medical Center. We had a public witness who was signed up to testify, but we do not see Dr. Phoenix. So we're going to go straight to our government witnesses. We'll hear from the UMC Chief Executive Officer, Dr. Jacqueline Payne Borden, as well as the UMC Chief Financial Officer, Ms. Lillian Trupama. The Not-for-Profit Hospital Corporation, commonly known as United Medical Center or UMC, is a District of Columbia government hospital serving Southeast DC and surrounding Maryland communities. UMC is an independent district instrumentality created by legislation adopted by the council in 2010. It provides inpatient, outpatient, psychiatric, and emergency care. UMC is governed currently by a fiscal management board, which serves as a control board and is led by Angel Jacobs as the designee of the Office of the Chief Financial Officer for the District of Columbia. And Ms. Jacobs sent written testimony for the record as she couldn't be here this morning. UMC will close once the new Cedar Hill Regional Medical Center opens at the St. Elizabeth's East Campus in early 2025. The committee sent written pre-hearing questions to UMC, and we will reference those materials today. If anyone watching, once again, would like to see those materials, they can be found online on the DC Council website at dccouncil.gov. I don't see any of my colleagues here, so I will turn to our government witnesses. And I think they know Dr. Payne Borden and Mr. Comic, because you guys have been with us before. We now have a new rule. Everybody has to be sworn in. So I ask that you raise your right hand so that we can see it on the screen. Do you swear or affirm under the penalty of law that the testimony you are about to provide the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth?
Yes.
Awesome. Okay, I don't know who is going first, but whoever it is, you can please begin.
That will be me, Chairperson Henderson.
Great.
Good morning again, Chairperson Henderson, council members of the Committee on Health and council staff. My name is Jacqueline Payne Borden, and I have the privilege of serving as the Chief Executive Officer of the Not-for-Profit Hospital Corporation, commonly known as United Medical Center, UMC. I'm joined today at today's virtual hearing by our CFO, Lillian Trupama. Before I begin, I would like to thank you, Chair Henderson, for your unwavering support to the hospital and community. I also want to thank the council and the fiscal management board as they continue to support UMC in achieving the goal of providing health care to our patients while maintaining the utmost standards of care that our patients deserve as we await the completion of the Cedar Hill Regional Medical Center. Over the past several years, the district has provided millions of dollars in operating subsidy to UMC for the ongoing support of the mission to provide affordable health care for the residents of both Wards 7 and 8. For the fiscal year 24 budget, we project a total operating revenue of $100 million and expenses of $99.3 million, with an operating margin of $734,000. The fiscal 24 budget includes the $15 million in district subsidy. In addition to the fiscal year 24 budget, the UMC leadership team will continue to operate and manage fiscal 23 budget within the parameters of our budget, being strategic in managing costs through greater accountability and transparency. For FY23, the contract labor budget was significantly increased from 3.5 mil to 7.8 mil to address staff shortages. I'm pleased to share that despite barriers with nurse and patient care technician recruitment, our newest supplemental agency has allowed for a more robust staffing model and a skill mix with the recent addition of agency nurses and technicians. This will guarantee that our patients continue to receive the highest level of care and staff are working within their scope of practice, particularly our licensed personnel. Our team is regularly monitoring our fiscal situation in our weekly initiative meetings to ensure that the fiscal year 23 budget is balanced. Work groups have been assigned tasks to monitor contract staffing, overtime, overall FTEs, and any potential duplicative managerial layers. In addition, contract services are being closely reviewed to determine the necessity and, if appropriate, adjustments or eliminations will be included in the closure plan and implemented following the adoption by the UMC Fiscal Management Board. As in FY23, there's no capital budget for FY24. The hospital will rely on the balance of the previous year's capital funding on hand to address any capital needs. Most of UMC's facility expenses will involve capital eligible repair and maintenance projects that will inevitably occur throughout the year, such as ensuring that the water, the heating, and cooling system remain functional. These repairs are essential for UMC to mitigate the high-cost emergency repairs, which we seek to avoid through required maintenance projects. With the closure of UMC approximately 2 years away, we are being very deliberative to only spend capital funds in core systems required to ensure that the hospital remains safe for patients and staff. At this time, barring any unforeseeable structural issues, I believe that these funds will be sufficient to keep UMC up to code through the end of FY24. UMC is currently working to create a permanent closure plan and will ensure collaboration with all stakeholders. An initial draft will be presented to the UMC Fiscal Management Board at the end of the third quarter of FY23. This plan will include a financial analysis of the cost of winding down services, operations, and maintenance. We will be examining all services provided at the hospital and determine whether the service is required to meet accreditation and licensing standards. Further, in drafting the plan, we will weigh factors such as patient volume, the impact of other District of Columbia hospitals, and the need for the services in the community. The council has statutorily mandated that we continue our emergency department and behavioral health services until the closure of UMC, and we will ensure these important services remain in place. In closing, we look forward to keeping you, Chair Henderson, and the Committee on Health fully informed. We are aware of the many challenges UMC faces during its final few years of operation. We understand that we are accountable to the UMC Fiscal Management Board, the mayor, the council, hospital employees, and patients. We will make the decisions necessary to ensure fiscal responsibility so that UMC's dedicated and resilient staff continue to provide high quality, evidence-based healthcare services for DC residents, particularly those residents in Ward 8 community, while keeping our budget balanced for FY23 and 24. This concludes my testimony. Thank you.
Thank you, Dr. Payne-Borden. And I think Ms. Jacoma is not providing testimony, just here to answer questions. All right, so we'll get right into it. Thank you so much for being here. And let me say at the top, so I've been on my hospital tours of late, and I need to come to UMC. So let's find a time where, because I think I have like 2 left, and you guys are one of the 2. So I want to make sure that I have an opportunity to come and see you in person. So according to the pre-hearing responses, there's a projected surplus in FY23 of 1.2 million. However, in the board minutes from January of 23, it indicated that if everything remained the same, then UMC would have a 10.7 million loss. Can you explain the difference here, Ms. Jacoma?
Yes, ma'am. How are you?
I'm good. Good to see you again.
Good, same here. Again, as you heard the chair, the CEO reading in her testimony, the executive team, am I on 2 places? Can you hear me?
I can hear you. We can see you.
Okay.
Yes.
The executive team has taken it as a challenge. A lot of focus, a lot of teams have been set up to make sure that we focus in balancing the budget. You know, most of the challenges she mentioned there, we have overtime has a challenge, and we have a focus for a team to, sorry about that, that's focusing on overtime. We have overtime of about $2 million that we're going to realize. On our revenue cycle, we have a lot of initiatives for revenue cycle to realize about 3 million of it, which is definitely sure. And also because these we have to cover because of the loss of dish. If you remember, loss of dish was our problem. So when we went to the board this past week, we went to the board, that 10.6 that you saw in January has moved to 6.9. So it's moving in the right direction, and we have factored in all the initiatives that we have on the plate that are materializing and will materialize more, but we're trying to be conservative. That's why it's at the 1.2 million that you see in our reforecast.
Okay, so the 6.9 when you went to the board this month, March, or?
Mm-hmm. Yeah,
okay.
It's for the month of February, but yeah, we just went to them last week.
Okay. All right. Hang on one second. Okay, I want to talk a little bit about patient care for a moment, which I think goes into sort of talking a little bit about the budget. In the March 23 minutes for the board meeting, it indicated that UMC has had an interdisciplinary team looking at length of patient stay. Can you talk a little bit, Dr. Payne-Borden, about what we're finding thus far? I've had these conversations with other members of the hospital association that we have some patients who they no longer need the acute care, but we don't have any place to discharge them to. And so they're staying for an unusually long time at the hospital. And I'm curious what this team is finding for UMC.
Yes, thank you for that. So UMC is similar to the other hospitals. A lot of times there are patients who they're hard to place once they're here. For example, for skilled nursing facilities, long-term care, we have had issues last month in particular with a few patients who placements were difficult, as well as there were some services, if they were admitted on the weekend, there are some services that could not be performed on the weekend.
Okay, and so, oh, go ahead, Mr. Kumar.
I'm sorry, if I may also add, this is just directly related to our budget because we have tons of homelessness, people that have no safe place to discharge them to, which is, of course, our clinicians are not going to discharge any patient unless they have a safe environment. We even have people that their families don't want them to come back. So the team is focusing on that because as our length of stay increases, it eats into our costs. So we spend more for that, more than the revenue we're gonna get. We spend more. So that is major, and they're finding it. We even had a presentation from the case management leader this past Tuesday to just show us a lot more of how much this is a challenge. And unless we get some help to where these people need to go to, it will be difficult. And that's one of the challenges that we have of finding the revenue when those patients come, but they're not really revenue because they are just cost prohibitive. So that's what they're finding. They're finding that is a major concern and there's no way out yet. So it's a big challenge that is still on the table.
So how many people are we talking about here?
Dr.
It is, or either one of you, like on average, how many people are we talking about?
On average, I would say about 5.
Okay, so you didn't say 50. 5 is not 10.
5 is not 10. However, each day that the patient stays, it impacts us, as Ms. Chakuma just said.
What's the longest length of stay at this point?
6.7. And we'll tell you, some of those patients.
You said 6.7?
Yes, some of those patients have stayed here more than 30 days, 40 days, which is every day is a burn rate. And these are patients that we are a medical hospital. And the length of stay, they should not be here more than 3 days. Highest, if they have comorbidities, should be 4 days. So when they go every day, that they might not be hundreds in number, but as they stay in every day, that's huge for us, for the cost to maintain them, because you have to still get the clinical care that they need to be monitored on a daily basis to make sure there are no other things that are happening while they are here.
Right. Dr. Payne Borden, is it their insurance won't cover long-term care or transfer to a skilled facility, or is it there's no space at a long-term care or skilled facility?
It varies, Chair Henderson, it varies. So there are sometimes when the insurance authorization is delayed, and the rehab facilities have no space, or as Mr. Kuma said, patients that are difficult to care for, sometimes the families are not receptive to receiving them back, or even some facilities do not want the patients back. And so UMC, we're here, we cannot just discharge a patient, in an unsafe situation. So that's what we are. We're a hospital. Unfortunately, we're an acute care hospital and not long-term. And so that's how the length of stays come into play.
Right, right. I mean, like I said at the top of this, starting this conversation, you guys are not the only hospital. We're starting these conversations with healthcare finance around what we can do from the government side to alleviate some of this burden. I think some of the hospitals had someone who was there for over 300 days, not needing the acute care, but because the hospital had no other place to discharge them to. So in terms of patient care, separate and apart from that, so long-term care, that's something that we're going to try to work on if we can. What changes have you all implemented in the last few years to decrease the number of sepsis infections and other hospital-caused infections? I think the number has gone down.
I didn't hear the leading part of your question. I apologize.
Around the work that you all have done to decrease the number of sepsis infections and other hospital-caused or hospital-based infections in patients.
So first of all our staff, they're very aware of how infectious diseases are transmitted. So all our infection control measures are in place and they are adhered to. If a patient has, for example, a Foley or an IV, they are assessed frequently and they are not left in place unnecessarily. They use it as needed and not keep it indwelling for a long time, which is how infections could begin if it's not cared for. So there are protocols if you have an IV, if you have a Foley, and so we stay on top of that. We don't indiscriminately put IVs in our Foleys as an example, if we don't have to.
Okay.
And so we have our rounding, we have our infection committee that meets, we have presentations monthly from the infection control department, and we transmit whatever information we need to our staff if there are any new initiatives, but we are on the ball with that. I'm proud to say that.
Great. For FY24, will there be any new programs or services that the hospital will be offering?
They're not at this point, no, ma'am.
I want to follow up from something that we talked about during the performance oversight hearing. It was a conversation I think you were having with Councilmember Parker, and he brought up about the potential move of the methadone clinic from Good Hope Road onto UMC campus. And I understand, Dr. Payne Borden, that you had some conversations with community leaders or clinic staff to sort of learn more. Is there an update on this?
There is no update. We're still at the same place.
Okay.
Whoever the liaison is did not reach out to schedule a meeting with all the stakeholders.
Okay. All right. The Department of Behavioral Health is preparing to open the first stabilization and sobering center next month in NOMA, which the hope is that, at least in conversations with FEMS and then also with DBH, that our emergency rooms across the city can see some release of pressure in terms of having patients for whom, again, they don't necessarily need acute care, but they need a place to stabilize and sober up, so they're not sort of just sitting in the emergency room. About that, have you been a part of some of the conversations around that? I know we're looking to open a second sobering center
I have not been.
Okay. Is that something that you all are seeing in the emergency room at UMC where it's, you know, you don't really need a doctor, you need a place to like stable and sober up, and then you can be discharged and moved on?
Yes, ma'am. On occasion, we do have patients who come in intoxicated and who needs that support to sober up. And as you know, we do not have a substance use disorder unit, but we do stabilize the patients in the ED. So our ED docs and nurses handle those types of situations.
Okay. Because one of the conversations, the second center that's included in this budget is for Columbia Heights. And I talked to the mayor a little bit about this in terms of that would be the second one. The first one is in Noma, technically Ward 5, but still close. The next one in Columbia Heights, the fact that we're not thinking about this from what are the needs for residents east of the river in terms of the distance. And so I was just curious whether or not there's sort of been any conversations about that. All right. I'm looking to see, I don't see any of my colleagues, so we're going to keep going. Let's talk a little bit about the end of the public health emergency. So I think everybody kind of knows where we're heading in terms of May and what that would mean. I am curious, Dr. Payne-Borden, though, given sort of recent conversations that have happened on Capitol Hill around ending the COVID-19 national emergency ahead of ending the public health emergency, is that going to change anything in terms of reimbursement and operations for your hospital in the immediate?
Chakuma?
Not at all. Not at all. It will not affect us in any way. We already, over the last 2 years, knowing where the COVID was and how it hit us and our surge level, we have factored in everything that will be impacted, but nothing is going to be impacted with the public emergency ending. So no, we're in good shape in that regard.
Okay. The second part of that, in terms of the end of the public health emergency, is the Medicaid redeterminations that are going to be taking place over the next 11 months or so. In terms of building the budget out for UMC for next year, have you all taken into account potential impact on revenues by seeing a number of patients who come to UMC who may no longer qualify for Medicaid and haven't yet done the paperwork and process to get on another health insurance plan?
Yes. As a matter of fact, over the past year or so, Medicaid has been changing. It has been moving to the managed care. So when I got here, Medicaid was about 34% of our revenue. Now we're about 8%. Yes, we factored in every potential thing that is out there in the 2024 budget, including the clinics that are being opened, all that we have factored in, yes.
Okay. Great. Let's talk a little bit about staffing. At the performance oversight hearing, it was mentioned that your contract labor budget increased significantly due to address staff shortages. In the March board minutes, you mentioned that UMC had contract with a staffing company, it's referred to as AYA.
Yes.
To address some of the shortages. What are the positions that company is going to be providing?
The company will be providing, and they have started to provide, nurses for the various departments, behavioral health, or med-surg tele, or ED, or ICU, as well as providing technicians for those areas as well. We do not have technicians in the ICU, so all the other areas except for the ICU.
Okay. And does this impact the spending that we're doing on contract labor? I guess it would obviously increase it. This is a separate company than what we use for nurses, right?
Yes.
Okay.
The spending, no, it would. As a matter of fact, that theirs is really much more, much more. I don't want to say cheaper, but more a little reasonable than the other ones. And so that you know, Chair Henderson, right now with our regular rate that we pay, and the overtime and the benefits, we are basically in the same place with the rate we're paying our clinic nurses, and then the benefits going to agency. That is why we're no longer worrying about agency. We just want them to be able to get what they need, because we have analyzed it and see that the cost is really, the difference is really not much for us. So we're good.
All right. So what percentage of UMC staff now are considered contract employees versus FTEs?
It's really maybe 7%, because it's really only for the clinical areas.
Okay.
Yes, we have a total of, I don't want to start you off now on the FTE numbers.
Well, that was going to be my next question. How many FTEs are we at?
Okay, we are at about 560 FTEs, but about 70 of those we are allocating to agencies. So you could say it's very reasonable.
Earlier this week, I went out to Cedar Hill Regional and had a conversation with, the team that's sort of doing all of that. And we're sort of talking as we're in this like sweet spot of 2 years out, but it's also kicking in some of the agreement things that were sort of laid out in the contract. And one in particular was around staffing and workforce training and development. And so my understanding is that healthcare finance is supposed to be providing you all with some funding soon to do the training institute with GW Cedar Hill team. Has that money transfer happened yet?
We are very close. We're about signing we have reviewed the draft of the MOU, and they just are finalizing some red lines, and the CEO will sign the MOU. But yes, it's guaranteed already as soon as that MOU is finished, which I think
yes, they sent it for our review as well, Mr. Kuma. As you know, you and I looked at it together, and so yes, it's almost finalized. So at least we are looking at the terms and everything, and we're really appreciative of this.
Okay, so what is the plan in terms of communicating with I'm going to be specific with my language, the eligible employees around what the schedule is, what the offerings are, et cetera?
That will be determined once we get everything in place, and most likely the training would be for all staff, including the registered nurses, if we're going to look at, for example, certification to verify that you are, example, a psychiatric nurse, or ICU nurse. There is specialized certification. So we'll look at certifications. We'll look at example, if a sitter wants to advance to a technician. So we're hoping that these fundings will help with that level of advancement, career progression.
Okay, my understanding though is that this is only for the 560 FTEs. It does not include contract employees. Is that your understanding as well?
That will be our plan. we wouldn't want to be paying the premium price we're paying agencies and trying to advance their employees. So that would be.
And I was like, I just want to be very clear. It doesn't include the contract folks in what is being planned.
No.
Okay. And so what is the anticipated start time from a schedule perspective?
If I may speak to that, I will say, because we are trying to weave everything together with this plan that we've told you we're preparing. Because all of them, the CEO and myself, we spoke and we planning on having a meeting with the larger stakeholders to have some good communication so that we get clarity on which direction we have to go for this plan to really finish and materialize. So it will be part of that. We're not going to do it in isolation and just so that we're not in confusion. We're going to put it all together and have the board approve of it and make sure that all of us are on the same page.
I understand. I guess what I'm trying to say is I don't want us to get to October and this hasn't launched. So when I ask for what is are we talking, we're going to get this off the ground by summer? Are we talking late spring? The agreement called for 2 years prior to, and I want to make sure that the employees and the workforce have the full benefit of that 2 years. If we are having these delays where this isn't starting until October, that's too late. especially since the money is there.
Right, we're eager to start. So once the MOU is signed, we will full force ahead, ma'am. We're eager for our staff to get the training as well.
Okay, great.
Yes.
Okay. I know these questions are also sometimes awkward to ask, but nonetheless, we must do so. Dr. Payne Borden, I guess, is there someone on your team who is the point person for the conversations with UHS, aside from the training piece, but as it pertains to the transition, if that makes sense? So one of the things that came up was around if you all have patients who don't need, if we go back, if you have patients in if in 2025, when we're about to start this, that you have patients who have been there for a long period of time, like we were talking about, who no longer need acute care, what happens to those individuals? Like, are we starting to have these types of conversations with the UHS team around timeline and I guess rules of engagement around the wind down procedures?
I think you were with Lillian and I last week. I'm just pretending because that's exactly what we were talking about.
Okay.
Here, Henderson, that as we begin this plan, this draft plan, that's one of the main things we're going to have to do is to engage with the UHS team. So we have not done that as yet, but it's on our list. One of our first things, additional things to do outside of the hospital to get our plan going. So we have a good idea of how this is going to work for our patients and for our staff.
Okay. Mr. Kuma, I want to follow up on one thing we talked about it at performance oversight in terms of the dish payment. Are we anticipating getting some of that money back for FY24 or how?
Go ahead. You know how to crack me up.
I'm curious in terms of the budget formulation piece of it. That was a significant chunk of money. That was not an insignificant amount of money in terms of what you all were receiving. And so I'm curious in terms of the plans around that for 24.
Okay. As you know, these challenges are not just unique to UMC.
Oh yeah,
me.
no, Howard had a similar.
The challenge. So what we do is it hurts, but the first thing we do is we take a detour. We find out what things we have to streamline without compromising care and make provision to balance our budget. Because as you know, as important as it is to give good clinical care, that's how important it is for us to do it financially responsible. So we have already made that provision of how the dish piece will be covered. We don't even know what's going to happen with dish in the future, but based on what we know now, we have considered the impact of what it will be for 2024, and we have factored that in, and we have provision for it. So, and there's nothing we could do about what has happened. I don't think it will come back to us, but you never know. Last year I received 14.9 million related to 2017 dish. So I don't know. So nothing, but based on what we know right now, no, I don't think I'm getting that one back. But miracles can happen.
Wait, did you say miracles can happen? Okay. Give me just a second. Okay. Dr. Payne Borden and Mr. Chikuma, is there anything you need that we haven't talked about from a budget standpoint?
I think your support for us is clear, and we know you're already going after things that are really the heartthrob, our heartthrob. So we are just in good hand because some of the things we're thinking, you're already ahead of us, trying to think about them and reach out to everybody. So I think we're good. But Jackie, you could.
Yes, I concur.
Okay. All right. Oh, wait. Oh, hold on one second. there's a back page. Oh, I asked this. Okay, great. All right. Great. Well, that concludes my questioning. If we have any follow-ups, we'll obviously reach out to you all in terms of that, as well as we can reach out to the CFO staff as well. Dr. Payne-Borden and Ms. Shukuma, I would like to thank you so much for, first off, your dedication to United Medical Center and the residents and the patients that you serve there, and providing your testimony and the information to the committee. If we have any additional questions, we'll follow up. But this concludes today's hearing. Excuse me, if anyone was unable to testify who would like to submit testimony for the record for either the Health Benefit Exchange Authority or United Medical Center, as I mentioned earlier, the record will stay open on this matter until 5 p.m. on Thursday, April 13th. You may email your statements to Ashley Strange at astrange@dccouncil.gov or leave a voicemail at 202-430-6046. If you choose to leave a voicemail, please speak slowly and spell your name for the record. Our next budget oversight hearing for the Committee on Health will be actually this afternoon. We'll be hearing from the public witnesses for the proposed budget for the Department of Behavioral Health at 2 p.m. today. But the time right now is 11:53 and this hearing is adjourned. Thank you so much. Thank you.
Thank you.